Okay, we're going to move to the next session, which is going to be on trauma. I'm Max Boachi from University of Louisville, and I'll be moderating with Jesse Bible from Penn State.
Now, Dr. Tim Moores from Cleveland is going to talk about our favorite patient cohort in the stiff spine fractures.
Thank you very much, Jason Maxwell. I appreciate the opportunity. I apologize I did not insert my disclosures. I get a teaching honorarium yearly from a company that I donate to the Metro Health Trauma Survivors Network. So those of you who know me know my integrity, maybe. So we're going to talk about pearls about stiff spine fractures. I gave this talk 4 years ago at CSRS, and I'm still scared to death of these fractures. So I've been in practice now 20 years at a fairly busy level 1 trauma center, so it doesn't get any easier. These ankylosing spondylitis or DISH fractures that we're talking about, these are unstable 3-column injuries. They're classified as A, O, B, and C, mechanically unstable. You want to minimize transport, okay? You don't want to bounce these patients around the hospital. Bad things happen if you do that. Think of it as a femur fracture with a spinal cord in the canal. So just to introduce the topic, a 70-year-old male, he won big at a racino. So we have a horse track with a casino, so it's a racino. He won big, he was jumped in the parking lot. His friend drove him to the ED. I got a nurse practitioner consult, and this is one of the issues, okay? These can be minor traumas. Oftentimes, there's no trauma activation. So I tell the residents and fellows, be scared to death of that consult from the ED, 4th year medical student, whatever, okay? The flags have to go up. You have to be very careful and diligent about evaluating these types of injuries. He was neurologically intact. He had some neck pain, and we were told the x-ray looked funny. Well, this is his CT scan. Not only does he have a stiff spine, but he has a horrible board of OPLL. So you have to be very careful with these types of injuries. What are the issues? Okay, why do our sphincters get tight when we're dealing with these fractures? Well, one is in the diagnosis. Oftentimes they're missed. Oftentimes they aren't evaluated appropriately. And the other is with technique of surgery. So why is there a delay sometimes? Because this can be a minimal minor trauma. It can happen a day or two before. Neck pain or back pain. Often there's no trauma activation. Okay, again, so general surgery trauma at level 1 trauma centers, the diagnosis is done. They've been scanned from stem to stern. So you just have to be very careful. You got to worry about non-contiguous injuries. You need pan-spine studies. The technique of surgery also creates some dilemmas. Do you do an MRI? I'll tell you my bias on that. What about the timing? You have a neurologically intact, that patient was neurologically intact. He comes in, racino, so it's, 1 o'clock in the morning. Are you going to let him wait until the next day? These are issues that we deal with. And then you have to treat these patients posteriorly, okay? And getting them to that position can be quite harrowing. So with neurodeficits versus intact, if there's a neurologic deficit, I like to do an MRI. I like to see what I'm dealing with. But I don't always, okay? If the CT scan correlates with the patient's neurologic deficit, oftentimes I won't, especially in a very unstable injury. MRI scanner in my institution is close to the hospital, okay? It's terrible, and I have a fairly well-run level 1 trauma center, but that's an hour to an hour and a half. And it's usually after hours, and the last thing that SICU nurse wants to do, he doesn't want to take that patient down to an MRI scanner. So you have to be very careful. You have to be a patient advocate with this. So I do like to do MRIs if there's a neurologic deficit with these, unless there's going to be a delay. If they say, we're not going to be able to bring him down for 4 hours. And obviously, if there's a worsening neurologic injury, I won't do an MRI. The timing, okay, so this patient, the racino patient, neuro intact. Do you do it now versus first case in the morning or whenever it's convenient. And everyone says, well, I need my A team. At Metro, there is no A team. There's a B+ team, 24/7, okay? And if you're going to be dealing with these injuries, you got to be able to take these patients at any time of the day. The worst thing that can happen with this patient is they go to the ICU, Q-hour neurochecks. I'm sorry, but it doesn't happen overnight. It doesn't. You round on him first thing in the morning at 5:30, he's not moving his legs, okay? So my bias is I take these now, especially in neurologically intact patients, especially, okay? That's my bias. Getting the patient prone, you can do it multiple ways. You can do anterior plating. You can do halo, okay? You can place the patient in a halo in the supine position, then take the patient to the OR, intubate the patient. You're not going to make friends with your anesthesiologist, but we're not there to make friends. We're there to take care of patients. And then you can roll them prone and take the back of the halo off. John Heller has a great story of a patient. He went out in the field to another hospital to put a halo on. So that's one very effective way of doing it. You can do the rotisserie Jackson flip. If you want to create tension in everyone in the OR, go ahead and do this, because it's always a dilemma. Or you can be very careful with a Mayfield. Awake intubation, yes, you can do an awake intubation, get your signals pre-flip, have the patient awake, roll the patient to the prone position, have them wiggle their toes, wait 10 minutes, I know, wait 10 minutes, and then off to sleep. So there's multiple ways to do it. I like anterior plating. It's just, I'll take the patient, if they're on a spine board, I will transport them with the spine board onto the OR table. I'll deal with the sacral decube. I don't care. I don't even want log roll that patient. So these are very unstable injuries. So just some data. This isn't a talk about data, but one of the good papers is out of, you can't have a good trauma paper without mentioning Harborview. 122 fractures in 112 patients, non-contiguous injuries, mostly C6-7 extension fractures. They're just really bad injuries, okay? So you got to be careful. You got to make sure that you identify and make sure you do pan spine studies. Excuse me. So combined anterior and posterior approach. There's really no difference in neurologic improvement from a meta-analysis. It is, 4 years ago, it was kind of just something new, but I think it's catching on a little bit. So if CT scan negative, you got to do an MRI, surgery less than 24 hours to limit progressive deficit, AP for cervical fractures, cement augmentation, because as we all know, these patients' spines, good cortical bone, but there's nothing after that. So what do we do with this guy? This is his CT scan. Who would order an MRI on this patient? Neurologically intact. Yeah. Okay. Maybe less, maybe about a third. I was scared to see what an MRI showed, actually. So I just, usually if the patient wasn't on anticoagulation, I think that's very important. And the patient was neurologically intact. So he got an operating room about 30 minutes after he hit the trauma bay. And this is what we did. So quick anterior approach, okay? And you say, Tim, well, your screws are in the disc space. If you can find the disc space, use it, because that's usually the best bite you get in these fractures. So of course we had to bend the plate, but quick anterior approach, cervical plate, that makes me more comfortable than rolling the patient to the prone position. Just one more case. 52-year-old male, fall from standing 3 days ago, okay? Minimal trauma, no trauma activation. He had some mild neck pain and chest pain. He had some difficulty swallowing, neuro intact. We got the call from the fourth-year medical student in the ED, okay? So this is his CAT scan, just a very typical Ang-Spawn fracture through the disc space. It's a 3-column injury. Try to break a piece of chalk on one side. You can't. It's a through-and-through injury. So what do we do here? Again, anterior approach, quick anterior approach, throw a plate on. I like to get 4 screws above the fracture, 4 screws below. And when I was little, I used to go over to my Aunt Betty's, and for fun, we used to just pound nails in blocks of wood. That's kind of what the posterior approach is here. So you just put your screws, I use 10-millimeter lateral mass screws straight in, as many points above the fracture, and then if I can get pedicle screws below. So it's very safe and effective. 74-year-old male, fall down 4 steps, neck pain. My head's in a much better position, doctor. He's neurologically intact. We were the 3rd hospital since his fall. These patients bounce around all over northeastern Ohio. We did have a general surgery trauma activation. So this is a sagittal CT scan. Absolutely neurologically intact. So again, I'm learning when to do MRIs more often, but I don't send this patient to the MRI scanner. I clear whatever I'm doing. If I'm in clinic, I get to leave clinic, which is always nice, but this patient goes directly to the OR. Again, a quick anterior approach. Now, the reduction can be a little bit harrowing, okay, when you go anteriorly, but it can be done safely, and then a long posterior construct. So the diagnosis is the issue, okay? These are often missed. No trauma activation often, okay? So be leery of that consult from the ED. 62-year-old guy, MVC a couple days ago, has some back pain. We did x-rays, they're negative. Can he follow up? That's a stiff spine fracture until proven otherwise. Pan spine imaging. If you find it, scan the whole spine, okay? Don't just, in some studies up to a third have non-contiguous injuries. MRI if needed, but be careful. MRI is not a place for an intact patient with an unstable spine injury. Those patients, we all know horror stories. Patient was neurologically intact when they went in. They ain't now, so be careful. Safe prone positioning, however you want to do it. Don't let anyone tell you how to do it. You use what's best in your hands, and as many points as needed. Thank you.
Hi, Ilyas Salim, University of Michigan. I had a question for Tim Moore regarding, you mentioned kind of the quick ACDF. I find sometimes with these patients, they have a lot of thoracic kyphosis and, almost chin on chest sometimes. And, sometimes it looks like you can do a quick ACDF, but then you actually look at them and it doesn't seem like it's going to be so quick after all. So I wanted to see if you had any tips and tricks for that. So that was one question.
So it's not an ACDF, it's ACF, right? Anterior cervical fusions, because you're just throwing a plate on. So typically they're extended, so it kind of opens up that space, and you don't need much. Okay, if you can get past the chin, everything opens up, deep to that. So unless it's severe chin to chest issue, but I won't reduce them until I do the approach and basically secure the plate distally, and then reduce the spine to the plate. I break scrub and under fluoro. I lift the head and try to get the spine reduced to the plate, and then you throw the screws in, and then you're home free. It's harrowing. I mean, I hate these fractures. And
yeah, the one thing.
I guess I was done.
No, I want to come back to that. So your guys, I'm just paraphrasing your thing. So the guy's been 2 weeks around Ohio, bouncing around between hospital to hospital. He comes in, he's got a broken neck. He tells you, hey, my neck's great. I love where it is. You take him to the operating room without any imaging. You take his head and you pull it to the plate. Correct? Do you use monitoring?
Yeah.
Okay.